So, good afternoon, all. And today the topic for step-in session is enteral nutrition in ICU. In ICU, I think nutrition for critically ill patient, nutrition is uh, very important to have a positive outcome of the patient, taking out the patient out of ventilator, getting the patients out of ICU, and also getting the patients out of hospital. So, nutrition is one of the important uh, aspect of ICU care. And so, specifically, nurses are the pillar who actually at the bedside give the feeding. It's always a teamwork, but give the feeding to the patient, maybe enteral nutrition, maybe parenteral nutrition. And in ICU, we get patient having multiple comorbid conditions, critically ill patient on ventilator, being dialysis, post-surgical patients. So, today's discussion basically will be on the enteral nutrition in critically ill patients in ICU. Yeah. So this is enteral nutrition. Enteral means oral nutrition may be if the patient is conscious and awake, if he is able to take oral nutrition. So oral feeding as early as possible. It's always better to give start oral feed. If not, if there is any patient is drowsy or GCS is low, then we put nasogastric tube, Ryle's tube. Ryle's tube feeding can be done. If any other complications are there, nasogastric tube feeding is not possible, then we give for prefer nasoduodenal feed, maybe nasojejunal feed, and urgent when required, as per the indications, gastrostomy tube and jejunal tube feeding can also be done. So the dictum is if the gut works, always use it. It is always the prefer mode, the enteral nutrition. But where there is any contraindication to the enteral nutrition, where we cannot give enteral nutrition, then we have to go for parenteral nutrition. Enteral means gut, so it's the nutrition to the gut, and parenteral means par means beyond the enteron. So directly to the venous system, maybe it's peripheral venous or the central venous, depending on the condition, we provide nutrition is the parenteral nutrition. So nutrition therapy is selecting the appropriate form. What type of enteral nutrition you can give? Depending on the condition of the patient, if the patient can take oral, as I said, oral diet and nutrition counseling is important. That what type of food you have to take. And if any the patient needs, the patient is malnourished or malnutrition is there, then supplementation has to be given. Oral diet plus oral nutritional supplementation has to be given. And if patient is unable to take oral feed, then as I said, tube feeding has to be started. And if there is any contraindication, then you go for the parenteral nutrition as per the guidelines. So this is the way how we go. Oral nutrition, if required, oral with some supplementation. If required, tube feeding. And if tube feeding is not possible, then go for the parenteral nutrition. So nutrition, any patient comes to our hospital, to the ICU or to the emergency department, first thing is that nutrition therapy, is it needed? If at all needed, then is the GI tract is functional? If the GI tract is functional, then we have to see if there is any contraindication for enteral nutrition. If there is no contraindication, we start oral or enteral nutrition as soon as possible. As per the guideline, within first 24 to 48 hours, we should start the enteral nutrition. But if there is any contraindication, then we go for the parenteral nutrition. So it is the preferred method of providing nutritional support to critically ill patients, and it is preferred over parenteral nutrition because of its simplicity. Enteral feed is it is simple to give, simple to prepare. It is better for the patient to absorb. Cost is low. Fewer infection complications are there, and ability to protect the intestinal mucosal barrier is there. However, feeding intolerance usually occurs during the enteral nutrition, leading to adjustment or discontinuation of the enteral nutrition. That means many a times patient having multiple comorbid conditions, maybe on vasopressor, single or dual vasopressor support. So many times feeding intolerance may occur. So you have to adjust or discontinue the enteral nutrition. So when the nutrient intake does not meet the body's metabolic demand, it can lead to malnutrition. Many times we get malnourished patients. So when to consider the enteral nutrition or tube feeding? When tube feeding is indicated, as I said, this is the way we go. And when the oral intake is less than 60%, the patient, we advise to the patients to take oral feed, but many times the patient do not take oral feed. They do not like hospital feed many times. So the oral intake is adequate. When it is less than 60%, oral intake is less than 60%, then we have to put the tube feeding. We have to start the tube feeding so that the calorie and protein intake are reached. In around 30 to 70% of ICU patients have GI dysfunctions. They have pre-morbid conditions, maybe any RTA patient having traumatic brain injury. Patients may be on non-invasive ventilation, may be on invasive ventilation, altered metabolic state. Patient may have sepsis, ARDS, then circulating stress hormones, got hypoperfusion may be there. Post-op surgical laparotomy patient may be there. Patient are on multiple medications. So GI dysfunctions occurs in around 50% of patients on mechanical ventilation. There many times aspiration staff come and say, sir, 200 ml RT aspiration has come, so I have not given the feeding. So around 74% of the mechanical ventilation patients fail to attain 80% of their desired calorie or protein intake targets. So factors to be considered are limitation of microbial contamination of feed, meeting adequate nutritional needs safely, ease of use and convenience of nurses, and cost effectiveness. Nurses are the persons who actually they remain at the bedside of the patient. They have within that 6 to 8 hours of duty, they have to prepare the food, give the patient to give the feed to the patient, maintain the drug chart. They have to do the any procedure. They have to stand there. Any shifting, any uh, admission to the ICU if any patient comes. So within that 6 hour, many times it may not be possible. So ease of use and convenience of for nurses is very important. And in our country, cost is a major factor. So formula fit specifically, wherever indicated, we have to see the cost and price. Meeting adequate nutritional needs, calorie and protein intake. Many times elderly patient, they are at home. When they come to the hospital, they're already malnourished. That has to be kept in mind. And limitation of microbial contamination of feed. In many hospitals, kitchen feeds are there to be provided as per the hospital protocol. So there is chance of contamination many times after giving the feeding. Patient have loose motion, diarrhea. So those things also have to be taken in mind. So why enteral nutrition is preferred? Because it maintains GI tract function and integrity. It stimulates GI contractility and trophic substance release. It supports gut and mucosal associated lymphoid tissues, prevent gut microbiota, prevents parenteral nutrition associated infective and metabolic morbidities. So when you give parental nutrition, the blood, so all these are avoided by giving enteral nutrition. So as I said, the dictum is if the gut works, use it always. So it is always preferred and as early as possible. Now, what the guideline says, the Canadian guideline, the American Society of Guideline, Australian guidelines. So all they advocate early use of enteral nutrition as early as possible, maybe within first initial 24 to 48 hours. So once the patient is stabilized, patient is in shock, patient is dyspneic on NIV. Once you stabilize the patient, as early as possible, the patient can take oral feed, go for oral feed. If oral feeding is not possible, patient is drowsy, it is risky, patient may aspirate, then you put a rail tube and start the feeding as early as possible. The meta-analysis compared complications of enteral and parental nutrition in 27 prospective randomized trial in a study by Brunswick and et al. And they have seen that though there is no difference in mortality, but the chances of infection chances are less. So in another study which compares early enteral nutrition versus delayed enteral nutrition in the Canadian clinical practice guideline for mechanically ventilated patients which are critically ill ICU patients, the result from the meta-analysis of 14 prospective randomized trials of early enteral nutrition versus delayed enteral nutrition showed that early enteral nutrition is associated with decreased reduction or 24% reduction in infectious complications and 32% reduction in mortality. So in this study, they found mortality benefit also, Haaland and et al. So now in enteral also again gastric feeding versus transpyloric feeding. So intragastric feeding by mouth or tube is possible in most post-operative patients, specifically post-surgical patients. But small bowel feeding in selected situation we have to give, like if there is high chance of aspiration, there is known gastroparesis, GI motility is less, intolerance to gastric feeding, patient having multiple episodes of vomiting, patient is drowsy, repeated and increased high gastric residual. So more than 400 ml GI residual volumes or more than 500 ml residual volumes, then you have to be cautious. Another thing, in many times we see surgeons specifically in post surgical cases, still they hear the bowel sound. No, the bowel sound is not there, we'll wait for another day. So it's not as per the guidelines, ASPN guidelines. Overt signs of contractility should not be required prior to initiation of enteral feeding. So always that, yes, bowel sound is, once bowel sound is hard, you start enteral feeding. No, the guideline do not suggest that. So it's not mandatory that bowel sound, if present, then start. It's not like that. As early as possible, depending on the clinical condition of the patient, enteral feeding can be started. So what are the challenges in critically ill patient to start the feeding? Critically ill patients undergo various physiometabolic changes. So these changes may increase the chances of malnutrition, and reduction in total calorie or protein intake may be there, and deteriorating the clinical conditions. Maybe vasopressor requirement goes on increasing, dual to triple vasopressor support, increase in sepsis, maybe fungal sepsis, maybe bacterial sepsis, rise in inflammatory biomarkers. Metabolic imbalance may result in multiple organ failure. Patient may go into AKI requiring hemodialysis, shock, refractory shock, and mortality. So these are the challenges actually in ICU patients. Up to 60% of ICU patients suffer GI dysfunction due to impaired GI motility, digestion, or improper absorption from the GI tract. Such GI dysfunction coupled with inadequate calorie intake leads mainly critically ill patients to develop energy deficit and lose lean body mass. So over those patients specifically, those neuro patients specifically, and ARDS patient many times, pancreatitis patient many times. So there is cumulative deficit in calorie and protein. So these patients usually stay for more than 15 days, 20 days, or 1 month in our ICUs. So if there is cumulative deficit in calorie and protein after 15 days or say 20 days, you see there is distinct visible malnutrition of the patient. So then we get difficulty in winning the patient from the ventilator unless the nutritional status is corrected. In such patients, taking them out of the ventilator is difficult. So thorough assessment of critically ill patient will help in deciding the strategy of nutritional support and further improve the patient outcomes. So once the patient comes to the ER, so immediately assessment for the malnourished nutritional status of the patient should be done. And as per the assessment, the scoring system we should do, and whether it is a malnourished patient or nutrition is adequate, then as per the dietary plan, nutrition to be given to the patient. And every day in critically ill patient, in ICU patient, every day during the rounds, we must assess the nutritional status of the patient. And if there is suppose loose motion 7 to 8 times of the patient, so yesterday's plan of calorie and protein may change today, and tomorrow again it may change. So every day during rounds, as we do the rounds for the medications, for the antibiotics, similarly for the nutrition, everyday planning must be done, and along with the dietitian if possible, the round should be along with the dietitian for the proper nutritional plan of each critically ill patient. So GI intolerance is post discontinuation of enteral nutrition, which is a sign of disturbed GI function and intolerance to gastric feeding. It has been reported as around 60% of ICU patients. So it may be due to energy metabolism or catabolism, delayed gastric emptying, fear of complications of gastric reflux, impaired intestinal barrier integrity, breach of mucosal barrier, abnormal motility pattern. Many times patient has vomiting, patient denies, no, no, I will not take, I have multiple episodes of vomiting. So these are so many factors for GI intolerance in ICU patients. So what is the consequence of GI intolerance? We see in diarrhea, there may be constipation of many patients, not passed stool since last 3 days or 4 days. There may be malnutrition, increased duration of that ultimately leads to increased duration of mechanical ventilation, increased duration of ICU stay, increased duration of hospital stay. As the duration of the hospital stay or ICU of the patient goes on increasing, chances of nosocomial infection also goes on increasing, and patient goes into the vicious cycle of infections, nosocomial infections, and multi-drug resistant infections. So these things should be kept in mind. So proper diet helps, enteral nutrition that helps in attenuates metabolic response to stress, modulates immune response, prevent metabolic deterioration, prevents loss of lean body mass, and decreases the length of hospital stay, decrease morbidity, improve patient outcomes. So proper nutrition is very important for critically ill ICU patients. So these are the few guidelines on nutrition for ICU patients, the ASPN guideline, Canadian guideline, ESPN guideline. So the calorie requirement is 25 to 30 kilocalorie per kg per day, and for the protein it is 1.2 or 1.5 to 2 gram per kg per day, and the body should be ideal body weight. So for male it is 50 plus 2.3 into height in inches minus 60, and for female it is 45.5 plus 2.3 into height in inches minus 60. So every day we do this, we calculate as per the ideal body weight the total calorie requirement and total protein requirement of the patient. So what are the recommendations? As we saw in the previous slides, it should be started as early as possible, preferably within 24 to 48 hours. Tube feeding should be considered if 50 to 60% of nutrition targets are not met adequately within the first 7 to 8 hours of oral nutrition. We start with a small feed for the patient. If the patient tolerates, then our target should be within the next 2 to 3 days to achieve at least more than 80% of the calorie and protein intake. But if the around even up to 60% the calorie and protein intake is not achieved in the first 3 days of 7 2 hours, then tube feeding, we should not wait for the oral feed. Tube feeding should be started. And if the nutrition requirement is not met adequately within the with the enteral nutrition, even up to 7 days of ICU admission, then we must consider the use of parenteral nutrition. So, what are the screening, nutrition screening programs or tests or scoring system and assessment and diagnosis? So, one is nutrition screening, the other is the nutritional assessment, and third is the management. So, coming to the nutritional screening and assessment, there are so many tools. It is imperative that nutritional assessment is done by well qualified trained nutritionists or dietitians in the ICU. Nutrition screening is done to identify and nutritional status of Indian malnourished patient can be assessed by SGA, subjective global assessment scoring system, and nutritional assessment is detailed evaluation of nutritional status of the patient. So complete nutritional history is the first step in nutritional risk assessment, and nutrition risk scoring, Nutrix score and NRS score 2002 can be used to determine nutrition risk in critically ill patient. So what is the difference screening and assessment? So screening is, it is quick and easy to obtain whenever the patient comes to the ER. You do the screening whether it is nutritional depleted or not. If it is nutritional depleted, then go to the assessment part, assessment of the patient, in which category the patient comes. So if it is in severe category, then plan for the what how I will how I am going to manage. I had a patient a few days back, a OP poisoning patient came from some other hospital after 7 days, saying when we received the patient was already malnourished. So he stayed in our ICU for about 1 month. So initially, the patient has many complications, pneumothorax, nosocomial infections, tracheostomy was done. After tracheostomy, winning the patient went into critical illness, myopathy and neuropathy. Only bone, just skin flap was there. So he was severely nutritionally depleted. It was very difficult to win the patient from the ventilator. Then we discussed with the dietitian, though there is around 35,000 kilocalorie deficiency over the last 20 or 25 days. So gradually we planned, gradually over the next say 15 days or 20 days, we planned how to replace this calorie and protein deficit. So gradually over the period of next 15 days, the protein and calorie deficit we reached up to some extent, and gradually the patient was weaned off from the ventilator, tracheostomy decannulated, and the patient sent home. So I mean to say that nutrition plays a very vital role in critically ill patient ICU patients, in getting the patients out of ventilator, getting the patients out of ICU. I always feel nutrition and physiotherapy are the two hands of any ICU. So without these two things, nutrition and physiotherapy, getting the patient out of ICU is difficult. So this is the nutrition support guideline recommendation in adult nutrition screening and assessment. Screening for nutrition risk is suggested for hospitalized patients. Nutrition assessment is suggested for all patients who are identified to be at nutrition risk by nutrition screening, and nutrition support intervention is recommended for patients identified by screening and assessment at risk for malnutrition or who are already malnourished. So this is the screening test for the initial screening. So is the BMI less than 20.5? Has the patient lost weight within the last 3 months? Has the patient had a reduced dietary intake in the last week? Or is the patient severely ill, like in intensive therapy, ICU, or malignancy patient? If the answer is yes to any question, then we go to the table 2. And if the answer is no to all questions, the patient is rescreened at weekly intervals. So again, after 3 to 4 days, we have to rescreen the patient. Now, coming if the patient is at risk, so then we have to go to the table 2, like as shown in the slide. So we have scoring systems 0, 1, 2, 3. We have to see normal nutritional status or weight loss more than 5% in last 3 months, and food intake less than 50 to 75% the normal requirement in the last week. Weight loss category 2 score 2 more than 5% in last 2 months, and score 3 more than 5% lost weight loss in last 1 month. So, and in severity of the diseases, similarly 0, 1, 2, 3. If 0 is normal nutritional requirement, score 1, any fracture, hip fracture, chronic patient, bedridden patient, COPD patient, diabetes patient. Score 2, major abdominal surgery, Whipple surgery, or laparotomy, post-laparotomy, stroke patient, malignant patient, recurrent hospitalized admission. And score 3, head injury patient, transplant patients. So we get the scoring from both the things, and finally the total score is calculated. If the score is more than equal to 3, the patient is nutritionally at risk and a nutritional care plan is initiated. And if the score is less than 3, then again rescreening of the patient after say 5 to 7 days be done. So this is the Bosch score. This is also similar. Few parameters are different. So different tools are there, and you have to finally like low risk, medium risk, and high risk. Finally, you have to calculate the risk and assess the patient. So this is also similarly another malnutrition screening tool, having step 1, step 2, step 3. You have to calculate the MST score, total score, and as per the risk, you have to intervene. And this is the SGA, subjective global assessment scoring. As you see in the slides, the one is A, B, C, history taking, physical examination, and subjective global assessment rating has to be done. Like weight changes, changes in dietary intake, GI symptom, functional capacity, and weight changes. So finally, you have to do the SGA assessment of the patient. Coming to the assessment, so malnutrition can be defined as a state resulting from lack of intake or uptake of nutrition that leads to altered body composition and body cell mass, leading to diminished physical and mental function and impaired clinical outcome from the disease. So we have to be very careful for that. And regarding the ESPN statement 2015 regarding the malnutrition assessment, so two alternative ways to diagnose malnutrition before diagnosis of malnutrition is considered, it is at risk of malnutrition by any validated risk screening tool. As we have seen in the last few slides, like BMI less than 18.5 and weight loss less than 5 in last 3 months, 2 months, 1 month, more than 5%. This is similarly the 2017 ESPN consensus statement. The ESPN criteria could be summarized that prior to the diagnosis of malnutrition, the criteria for being at nutritional risk according to any validated nutritional risk screening tool must be fulfilled. So this is the GLIM global new global leadership initiative for malnutrition that takes into account non-volitional weight loss, BMI, reduced muscle mass, reduced food intake, and disease burden or inflammation. So this is the tool, and this is how we go. The initial risk screening should be done for malnutrition. Then assessment criteria, diagnostic criteria has to be done, and here it includes the phenotypic criteria that includes non-volitional weight loss, low body mass index, and reduced muscle mass. And then diagnosis meets the criteria for malnutrition diagnosis, requires at least one phenotypic criteria and one etiologic criteria. And that ultimately leads to the severity of the grading. So after initial nutritional screening and assessment by these tools, now as per the severity of the malnourishment or malnutrition condition of the patient, we have to do the intervention. We have to intervene. So as I said, the calorie requirement is 25 to 30 kilocalorie per kg body weight, and the protein requirement should be 1.5 or 1.2 to 2 gram per kg body weight, ideal body weight. Now, coming to the importance of the micronutrients. So, pre-existing micronutrient deficiencies should be evaluated, assessed. Many times we miss this micronutrients requirement in ICU patients. We miss many times, and electrolyte deficiency also we miss many times. Patients on formula feed may not require additional micronutrients, vitamins, and trace elements if they are on complete and balanced formula feeds. So many times patients are already on formula feeds, so for them any supplemental micronutrients addition may not be required. But micronutrients can be supplemented in patients on blenderized feeds and those on enteral nutrition. So in many hospitals, the blenderized feed or kitchen feed the patient receive as per the protocol of the hospital institution. So in those patients, some supplemental micronutrients may be required to added. Now coming to enteral tube feeding versus parenteral feeding. So as we discussed, enteral nutrition is preferred always, and the parenteral nutrition even after 7 days of giving tube feeding, enteral feeding, if the around 80% of the target is not actual nutrition. However, combination of enteral and parenteral nutrition should not be routinely recommended except for specific indications. In few times, we overlap with that if required as per the indication of the patient, but routinely it should not be given. So, indications for feeding, like in this head injury patient, ventilated patients, having swallowing disorder, having liver disease, esophageal stricture. So in these cases, we can go for this, and enteral tube feeding is preferred. So, nutrition monitoring in critically ill patients. So, identification of patients at risk of feeding intolerance may assist in development of strategy to monitor and manage nutrition intolerance. This will ensure adequate delivery of nutrients to the critically ill patients. So, what are the recommendations for the monitoring nutrition tolerance and adequacy? Like many times, our staff says, "Sir, in last 4 hours or 5 hours, 200 ml, 150 ml gastric residual volume was there, so I have not given the last feed." So this is so many times what we advise during our rounds to the patient, actually the patient doesn't get that. Patient going for CT scan, patient going for MRI, no, the last 2 feeds we have hold. Patient was extubated, no, the previous 2 feeds was not given, and post extubation also the last feed has not been given. So all these things ultimately leads to cumulative calorie and protein deficiency. So gastric residual volume should be measured by syringe aspiration and not by suction pump. But now the guidelines also says at each feeding, aspiration of the gastric contents is also not mandatory. And GRV less than 300 ml can be refeed. It is not required that you take it out and throw it. And holding enteral nutrition for GRV, gastric residual volume less than 500 ml in the absence of other signs of intolerance should be avoided. So if it is less than 500 ml, unnecessary stopping enteral feed should be avoided. And prokinetic agents like metoclopramide and erythromycin can be recommended in these patients with intolerance and risk of aspiration. So those can be added. So this is the flow chart for the that we have discussed till now. Patient admission, check patient hemodynamically stable as early as possible. We can start the enteral feeding. If yes, oral patient can take oral feed, start oral feed. If no, then put a RLCU, start tube feeding. If contraindication to the enteral feed, start parenteral nutrition. And after tube feeding, check tolerance whether the patient is tolerating or not. If the GRV is less than 500 ml or more than 500 ml, if patient tolerating, feed, start and continue enteral nutrition. As the condition improves, as early as possible, condition improves further, again try to start oral feed with a sip of water if the patient tolerate, or semi-solid or semi-liquid diet. And if patient tolerate, then change over again to oral feed. But high prevalence of feeding intolerance, those patients having on vasopressors, ventilator, dilator, the dialysis, critically ill patient, many times high prevalence of feeding intolerance we see in patients. So in those patients, specialized formulas are there also available, that supplementation may be added to their enteral nutrition. So, if it is not in many patients like cardiac patients, CKD patient, dialysis patient, there is some volume restriction. So, in those patients, with a less amount of volume, some protein supplementation, calorie supplementation can be done. In specifically in blenderized feed, in kitchen feed, many times we need to add those in specifically in cardiac patients and CKD patient, maintaining the TFI is 800 ml per day or 1000 ml per day. Hello, am I audible?
Yes, yes, sir. Yes, sir.
Yeah. So there are some issues in the internet logistic issues. So to summarize my talk, uh, enteral nutrition in ICU is very important. Enteral nutrition in ICU is very important, and as early as possible. So we should start enteral nutrition and preferably oral feed, and wherever not possible, we should go for tube feeding. And if the nutritional calorie and protein intake is met, then uh, as early as possible within first 72 hours we should do that. And if not possible, supplementation of the formula feed should be done, so that nutrition deficit and calorie deficit of the patient can be met. Am I audible?
Yes, sir.
Yeah, any queries from any of the participants?
Recording in progress.
Participant can write their question.
So any queries from any participants? Sorry for the interruption. There are some logistic issues here. So it was discontinued. Deepa, is there any queries?
No, sir.
There is some interruption in between. My network got disconnected. There are some issues.
Okay, sir. No problem, sir.
So there is no queries. What is the
Uh,
aspiration protocol for? Yeah, there is one question. Sir, what is the aspiration protocol for continuity riles to feeding? As I said in my slides, so if the gastric acidic volume is less than 500 ml, so you can go ahead with the riles to feeding. You need not interrupt. And the prokinetic agents like erythromycin or metoclopramide can also be added. So, like repeatedly, our staff they stop feeding 200, 150 ml GRV. They stop feeding. We should not stop. That should continue if the GRV is less than 500 ml. Any other queries?
No, sir. So we wait for 2-3 minutes. If there is no question, so we will end the session, sir.
Okay.
There is no question, sir. So with your permission, I'll end the session, sir.
Okay. Okay.
Conclude the session, sir.
Yeah. So to conclude the session, enteral feeding is one of the important aspects of critically ill patients, and few take-home points as early as possible. Start enteral nutrition in critically ill patient, but before that, assessment risk screening of the patient when they get admitted to any hospital or ICU, that has to be done, and then proper after assessment has to be done. Scoring system, the simpler the Nutrix score can be done in ICU, and depending on that, we plan for total calorie and protein intake of the patients, and every day daily calorie and protein intake of the patient should be done. And if there is cumulative calorie and protein deficiency of the patients, then you have to calculate on the on how many days we have to adjust this protein and calorie deficit for the patient. And if the calorie and protein intake is not met within the 7 days of tube feeding, then we may switch over to parenteral nutrition as and when indicated. So thank you. With this, we come to the end of today's session. Thank you.
Thank you, sir.
Thank you.